think that in terms of the number of cycles that the average, Shilpa said that we got to 12, which I think is true for both drugs, but are we, are you pushing the enfortumab vedotin through, or are you getting to sort of 6 or 8 or 10 cycles and beginning to say to patients, you know what, we might miss day 8, we might do the 3 weekly cycles, we'll come down a bit on the dose. What's your take on that?
Tom, traditionally over the last few years since enfortumab was approved by the FDA, I take the approach of starting in most patients at least, not that frail, but most patients, with full dose.
Sure.
But I literally look for reasons to dose reduce.
Right.
After the first 1 or 2 cycles, usually people have some degree of neuropathy. The more you
But it's a bit unpredictable, isn't it?
The more you find.
I've got a lady in her 80s to just zoom through this. Yeah. Which I thought was really odd. And she's still going on. And she's an amazing woman. She's from Eastern Europe originally, came to the UK and worked as and it was cleaning in her.
It's unpredictable.
And it was, I thought, oh God, we're going to really struggle. She's about 45 kilograms and she went straight through.
And I have a patient who's had bulky retroperitoneal nodes. After initial NMIBC, 5 years later, presented with bulky nodes, put him on EV 302. And he's now 2.5 years out, done with Pembro, CR after the first scan. I could not believe that was his scan. And he's cruising through also. I have to find for reasons to not give the EV to him.
Because they're doing so. So it's unpredictable, to your point. And some patients do great, but I think the educational part is key.
Super important.
And skin exam. When patients come to my clinic, I do a skin exam because in my experience, patients always underreport things when they are benefiting from treatment, especially drugs like EV.
Yes.
But for chemo, every little thing is over-reported.
Sure.
So I make them walk for the gait because motor neuropathy is also underreported.
Sensory and motor accumulating with time, and if you treat through neuropathy, you get into a lot of trouble.
Right.
Absolutely.
I just saw a patient 3 days ago treating in the community with EV monotherapy, and she came in, her skin was peeling, and she was still getting EV. They just told her to put a steroid ointment. So I think,
I don't like that.
right? I think that it's so important because that was so worrisome even to me.
And to prep, to your point, Shilpa, the patient upfront, Tom, to your question, before you start the combination or EV alone, to prep the patient and say that we might at some point dose reduce or hold or adjust, and that's okay.
Yeah.
So you set the expectation up front. And the other important point, Tom, that I think you mentioned already, that in addition to education of the patient, also education for the team, our APP, our nurse, our pharmacy, because the team that manages that patient. I think to the other point that you made, it will be a great time going forward to do the escalation trials. To answer your question, Shilpa, how much EV we need, I think it was the right design, Tom, to have EV at least until progression toxicity for this trial, but going forward, I would love to see the escalation trials to evaluate how much we need.